my name is Lynn, and I'm a family nurse practitioner student at West Texas A&M University. I will be performing a head-to-toe assessment on a 23-year-old male patient who is here to establish care. I've obtained his medical history, past surgical history, family history, allergies, and medications. He denies any medical history and has no known drug allergies. I've obtained his height, weight, and calculated his body mass index, or BMI, and it was within a normal range. I've obtained his vital signs, and they are also within a normal range. I performed a visual acuity test using the Snellen eye chart. This test cranial nerve number 2, or the optic nerve. The patient has bilateral 20/20 vision without correction. I performed the proper hand hygiene, and now I'll begin the head-to-toe assessment. I want to make note that throughout this examination, I'll be looking at the patient's hair distribution, skin color, and noting any skin discoloration, such as jaundice or yellowing of the skin, which could indicate a liver problems. Making note of any ulcers, lesions, moles, or nevi. I want to make note that the patient does have tattoos. There's one on the right inside of his bicep, and then the left inside forearm. Perfect. I'm going to look at the patient's nail beds, noting the color and the capillary refill of the fingers and of the toes, making note of any clubbing, which is abnormal and could be prolonged decreased tissue perfusion, such as in COPD. Now I'll begin the inspection and palpation of the head and neck. So I'm going to start with the scalp. I'm going to make sure that the scalp is intact. There's no lesions, bony nodules or prominences, no open sores. There are no areas of hair loss or hair thinning, which could be a concern for alopecia or thyroid issues. I'm going to feel the hair texture, look at the hair shaft, making sure there's no breakage and there's no lice or dandruff, which none is noted. From here, I'm going to palpate the temporal pulses, making sure that they're 2+. I'm going to palpate the patient's frontal sinuses and maxillary sinuses, making sure that there is no tenderness noted. From here, I'm going to test the patient's trigeminal nerve, which is cranial nerve number 5. I have a cotton-tipped applicator with one end being sharp and the other end being dull. I'm going to get the patient to close his eyes and tell me if he feels sharp or dull. Okay, can you close your eyes for me?
Sharp, dull, sharp, dull.
Perfect. Okay, now I'm going to look at the patient's temporal mandibular joint, or TMJ. I'm going to ask the patient to open his mouth for me. I should be able to place 2 to 3 fingers behind. Ask the patient to close his mouth and then move it side to side. Notice any audible clicking or popping or difficulty, which I do not note. Great. From here, I'm going to move to the eyes. I'm going to make sure that the eyes are symmetric to the face, looking at the sclera and the conjunctiva, and making sure the sclera is clear and white. There's no yellowing that could indicate jaundice. And making sure the conjunctiva is pink and moist. There's no excessive tearing or discharge. Looking at the hair distribution of the eyebrows and of the eyelashes. And then I'm going to look at the pupillary response with a direct and consensual reaction to light with the pen light. I'm going to shine the pen light in the patient's eyes and look straight ahead. Perfect. And direct and consensual on this side. Great. The patient's pupils are 4 millimeters and they dilate to light, which is appropriate. And now I'm going to do accommodation. I'm going to ask the patient to look at the pin light and the wall behind the pin light, the wall, and then the pin light. Pin light, and then the wall, and the pin light, and then the wall. Perfect. And that looks great. Now I'm going to test cranial nerves 3, 4, and 6, which is the ocular, trochlear, and abducens, with the 6 fields of gaze. I'm going to ask the patient to not move his head and only follow the pin light with his eyes. Okay. And that looks great. And now we're going to take a look at the eyes, at the optic disc, making sure that it is sharp, making note of any papilledema or AV nicking, and noting the red reflex. I'm going to place my hand on the patient's head for stabilization. Look. Okay. And on this side. Perfect. Great. Okay. 10, none is noted. From here, we're going to go to the ears, and we're going to make sure that the ears are symmetric to the head, palpate the auricles, making sure there's no nodules, tenderness, or lesions, which there's not. Then we're going to take a look inside the ears with the otoscope, looking at the tympanic membrane, making sure that the landmarks are identifiable. There's no bulging, redness, or swelling, which could indicate an infection. Okay. And with the adult, you're going to pull the pinna up and back and look inside. Perfect. And then on the other side. Great. And everything looks good in there. From here, we're going to test cranial nerve number 8, which is the acoustic to whisper test. I'm going to ask the patient to repeat after me.
55. 66.
Great. And now we're going to do the Weber and the Ryan test. Ryan test, I'm going to be using the tuning fork. For the Weber test, it is a lateralization of hearing in both ears. I'm going to ask the patient if he can hear the noise in both ears.
Yes.
Perfect. And then for the Ryan test, it is an ear to bone conduction with a normal ratio of 2 to 1. I'm going to ask the patient if he can, or to tell me when he can stop hearing or feeling the vibrations, and I'm going to place the tuning fork on the mastery process.
No.
Okay.
No.
Okay, great. Okay, and from here we're going to go down to the nose. We're going to look at the nose, make sure it's midline to the face, make sure the septum is midline, there's no deviation. We're going to test the patency of the nose. I'm going to include one nostril and ask you to breathe in, and then the other one. Perfect. And now we're going to test the olfactory nerve, which is cranial nerve number 1. I'm going to hold something under the patient's nose as he closes his eyes, and he's going to tell me what the smell is. Okay, close your eyes for me.
Rubbing alcohol.
Perfect. Great. And now we're going to take a look inside the nares, making note of any polyps, redness, or excessive discharge. Great. None of that is noted. Perfect. From the nose, we're going to go down to the mouth and the lips, making sure that the mouth is midline with the face. The lips are pink and moist. There's no sores, cracking, or discoloration. I'm going to have the patient open his mouth. Looking at the oral mucosa, making sure it's good and pink and moist. And I'm going to get you to lift your tongue up. Looking for any ulcers, lesions, or cancer, and none is noted. And now we're going to test cranial nerve number 9, which is the glossopharyngeal or the gag reflex. I'm going to place a tongue depressor. So you turn. Yeah, perfect. And then we're going to test cranial nerve number 10, which is the vagus nerve. I'm going to ask the patient to stick his tongue out and say, ah, making sure that the uvula rises midline. Perfect. Now we're going to test cranial nerve number 12, which is the hypoglossal. I'm going to ask the patient to stick his tongue out and look and move it side to side. Perfect. And looking for lesions or ulcers or cancer, which none is noted. With the last two, it's going to be cranial nerve number 7, which is the facial. I'm going to ask the patient to smile, frown, raise your eyebrows, and puff out both cheeks. Great. And then for cranial nerve number 11, which is spinal accessory, I'm going to place my hands on the patient's shoulders and have him shrug them up to me. Great. And then from here, we're going to move down to the neck. I'm going to look at the patient's trachea, making sure it is midline. There's no deviation. There's no trouble swallowing or any trouble with respirations. I'm going to palpate the patient's thyroid. I'm going to stand behind and place my hands on either side of his neck and get him to lean forward and swallow as I palpate. Perfect. There's no goiter, enlargement, or any nodules. And I'm also going to palpate the patient's lymph nodes, starting with the pre-auricular, the post-auricular, the submandibular, the submental, the cervical, the post-cervical, the supraclavicular, And then also I'm going to palpate the axillary lymph nodes. Perfect. Making sure they're not enlarged, there's no swelling, tenderness with palpation. Perfect. And now I'm going to test the range of motion and the strength in the neck. I'm going to ask the patient to tilt his head side to side. Perfect. Forward, and then back. And then I'm going to place my hand on his head and ask him to push against it. And great. Okay, and now I'm going to feel the carotid pulses, making sure that they're 2+. I'm going to do these individually. Okay. Great. And now I'm going to auscultate for any carotid bruit or swishing noises. Okay. I'm going to ask the patient to inhale and exhale and hold. Perfect. Same thing. Inhale, exhale, and hold. Perfect. And no bruit is noted. From here, I'm going to look at the patient's posterior chest. I'm going to ask him to turn around on the bed for me. Okay, great. And with this, I'm just going to do a general inspection, looking for even chest rise and fall, no use of accessory muscles. I'm going to test the even chest rise and fall. I'm going to place my hand on either side of his spine and ask him to take a deep breath in and out. Perfect. Perfect. And making note that my thumbs rise and come to midline symmetrically. Perfect. And from here, I'm going to feel for any tactile fremitus. I'm going to ask the patient to say 99 as I work my way down. Repeat. 99.
99. 99. 99. 99. 99.
Perfect. And there's no increased or decreased tactile fremitus. Now I'm going to be testing for CVA tenderness or costovertebral angle tenderness and asking the patient if he feels any pain with this movement. Any pain with that?
No.
Okay, great. And now I'm going to be percussing the lung sounds, noting any hyperresonancy or dullness. The lung sounds, the lung field should be resonant. Signs of air or infection in the lungs would be sounds of dullness, and hyperresonancy would be hyperinflation with COPD or asthma. And I'm going to be working in a ladder-like pattern. Okay, perfect. And now I'm going to test for diaphragmatic excursion. I'm going to ask the patient. I'm going to ask the patient to hold his breath, or I'm going to inhale and hold his breath, and I'm going to percuss down to the area of dullness. And inhale and hold. Okay, perfect. And make a note of that. You can breathe normally. Breathe normal. Perfect. And then I'm going to get him to inhale, exhale, and then hold. Okay, inhale, exhale, and hold. Perfect. And making note of that, in that area is the diaphragmatic excursion. Now I'm going to auscultate the breast sounds, making note of any adventitious sounds such as crackles, wheezing, or ronchi. Okay, take deep breaths for me. Okay, perfect. Breathe normally. Great. And now I'm going to auscultate for bronchophony or agophony, asking the patient to repeat after me as I work my way down. 99.
99. 99.
E,
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 E.
E.
No bronchophony or abronchony is noted. If it was present, it could be a sign of pneumonia. So now I'm going to ask the patient to turn around, and I'm going to be doing the anterior chest. Great, perfect. Just going to do a general inspection. I'm making note of the work of breathing, any use of accessory muscles, which none is noted. Perfect. And now I'm going to palpate for any heaves or thrills with the pads of my fingers or the palms of my hands. Perfect. And none are noted. I'm also going to be looking at the AP diameter of the chest, making sure that it is not barrel chested and the patient is not. I'm going to be palpating for the PMI, or the point of maximal impulse, which is at the apex of the heart. This patient is thin and healthy, so I should be able to palpate it. Perfect, and it is palpable. And now I'm going to be percussing the lung fields, making note that they are resonant, there's no hyperresonancy or dullness. Perfect. And then from the percussion, I'm going to move on to the auscultation. Great, and there's no adventitious sounds noted. I'm going to next be listening to the heart sounds. I'm going to be first starting at the second intercostal space, right sternal border, the aortic valve, and then the second intercostal space, left sternal border, which is the pulmonic valve, moving down to the third intercostal space, left sternal border, the fourth intercostal space, left sternal border, which is the tricuspid valve, and then finally ending in the apex of the heart, fifth intercostal space, or the mitral valve. I'm going to ask the patient to slightly lean forward for better hearing. Put your other side forward. Perfect. Great. Noting strong S1 and S2 sounds and no extra heart sounds. Now I'm going to be listening for any heart murmurs, and I'm going to be using the bell of my stethoscope. So that's slightly again. Perfect. Working from the base to the apex of the heart. Perfect. Now I will be testing for jugular venous pressure, or JVP. I'm going to ask the patient to lay all the way back, and then I'm going to raise the head of the bed up slightly to 30 degrees. Great. Lay all the way down. I'm going to get him to turn his head slightly to the left, and I'm going to be looking at the right side, the external jugular vein. I'm going to get my centimeter ruler and a flat index card, which is my smell and eye chart. I'm going to be looking at the meniscus of the external jugular vein. I'm going to place my centimeter ruler at the sternal angle and the highest point, and I'm going to measure straight across, noting that it is a little over 3 centimeters, and normal is 3 to 4 centimeters. Increased JVP would be a concern for heart failure. And since I'm here, I'm going to lay the head completely flat, and I'm going to assess the abdomen. First, I'm just going to do a general inspection, making note of any abnormal pulsations or bruising or any masses. And then I'm going to auscultate the patient's vowel sounds as well as the aorta and the femoral arteries, noting any brewery or squishy noises. Okay, perfect. The patient's bowel sounds are normal active. They are not hyperactive or hypoactive, and there are no breweries noted at the aorta or femoral arteries. And from here, I'm going to percuss the abdomen. Or actually, before I percuss the abdomen, I'm going to check the liver span. I'm going to go from the right of the umbilicus. I'm going to percuss up to the area of dullness, which is the bottom of the liver, and then I'm going to go from the bottom of the nipple line on the right side and percuss down, which is to the top of the liver. Then I'm also going to percuss for the spleen and note the splenic dullness. I'm going to percuss the rest of the abdomen, noting areas of tympany and dullness over the organs in an empty or in a full bladder. Perfect. And from here, I'm going to palpate. I'm going to do a light and a deep palpation, starting with the light and just working my way over the whole abdomen, noting any abnormal masses. Okay? And then with the deep palpation, I'm going to place my hand under the patient's back, and I'm first going to palpate the spleen, asking the patient to relax as much as possible and take deep breaths. And then the liver feels smooth. And then I'm going to palpate for the spleen, which I cannot, which is normal. And then I'm going to go down to the left kidney, and then down to the right kidney. And while I have the patient lying flat on his back, I'm going to test for herniated disc. I'm going to ask the patient to raise this leg up, and I'm going to get you to pull your toes to you. Do you have any pain with that? Okay, I'm going to get you to do the same with this leg and pull your feet towards you. Okay, great. And now we're going to test for range of motion in the hips, the knees, and then the ankles. So with the hips, I'm going to get the patient to flex and then extend, and then we're going to abduct, and we're going to adduct, and then we're going to external rotate and internal rotate. Perfect. And then the same on the other side. Okay. Flexion of the hip, extension, abduction, and adduction, and then external rotation, internal rotation. Great. And then the same with the knees. I'm just going to get you to bend your knees up. Okay. And then flex out. And then we're going to do external rotation, internal rotation, and then the same with the other one. We're going to do flexion, extension, external rotation, and internal rotation. Great. And then with the ankles, I'm going to get you to, I'm also going to test the strength in the ankles. I'm going to get you to push against my hands. Great. And I'll pull against my hands. Perfect. Any pain with that? Great. And now I'm going to get you to sit all the way up. You can sit on the edge of the bed. Perfect. Okay, and then once your gown is on, and then I'm going to get you to stand up, and we're going to test the range of motion in the shoulders. And I'm going to get you to raise your arms out like this. Okay, and then I'm going to get you to cross them over like this, and that's abduction. Okay, and then make sure to get you to put them behind your head like this. External rotation, and then behind your head, and that's internal rotation. Perfect, and then you can have a seat. Great, and now we're going to be looking at the the neuro. We're going to be doing some neurosensory checks. First, I'm going to do is number identification. I'm going to get you to close your eyes and hold your palm out. Okay, close your eyes and tell me what number this is.
8.
Perfect. Okay, and now we're going to be doing what's called sternosis, and I'm going to be putting an object in your hand. I'm going to get you to close your eyes, and I'm going to get you to tell me what it is. So close your eyes. Can you tell me what that is?
Paperclip.
Yes, perfect. Great. And now we're going to be doing some more neurosensory checks. We're going to be doing point-to-points in the upper and lower extremities. I'm going to get you to close your eyes, and I'm going to get you to hold your hands out for me. And I'm going to tap a finger, and then whatever finger I tap, you touch it to your nose, okay? Great. And now we're going to do point-to-points on the lower. I'm going to get you to touch your left heel and run it up and down your right shin. Perfect. Okay, and then the same with your right heel on your left shin. Okay, great. And then I'm going to be doing some other range of motions. I'm going to be doing that in your wrist. I'm going to get you to pronate and supinate, so flip your hands over. Great. Faster. Can you get faster? Great. And that's test cerebral function as well. I'm going to be testing hand grips. So I'm going to get you to grip my hands as hard as you can. Perfect. Noting any signs of muscle atrophy or weakness, which none is noted. I'm also going to be doing some more neurosensory checks, proprioception. So I'm going to get you to look straight ahead, and then I'm going to move your toe either up or down, and you tell me which way it is.
Up.
Okay, great. And that looks perfect. Now we're going to finish with our pulses. We've already done the temporal and the carotid, and we're going to finish with the brachial, and then the radial. Perfect. And then the popliteal, and you use both hands for these. You need to do those bilaterally. Great. You're going to do the posterior tibialis. And then the top of the feet is the dorsalis pedis. Great. And then we're going to finish up with the reflexes. We're going to start with the tricep reflex. I'm going to get you to just relax your arm out just like this for me. Just relax it in my arm. Relax it in. Perfect. Great. Okay. Perfect. And then we're going to do on this side. Relax it. Okay, great. And then we're going to do the brachial radial. Great. And on this side. Perfect. And then we're going to do the patellar. Okay, great. And then we're going to do the Achilles. And then the Achilles on the other side. And those look great. From here, we're going to finish up with the neuro. I'm going to ask the patient to stand up. We're going to test for ataxia. This is going to be the Romberg test. And I'm going to get him to step away from the bed. I'm going to get you to close your eyes. Perfect. Noticing any loss of balance, which he did not have. And then I'm going to get you to walk. I'm going to get you to turn around and walk heel to toe as far as you can. Great. And then I'm going to get you to turn around, walk on your heels, and then walk on your toes. Great. And that looks perfect. So I'm going to get him to sit down. That ends the physical head-to-toe assessment, and now I will be doing a discussion about the female and the male genitalia, breast, rectal, and prostate exam. So with the female breast exam, and with any of these, you will need to have a licensed professional with you doing these exams. So for the female exam, you will be working in a vertical strip pattern, working circular motions from the clavicle to the bra line to the axilla to the sternal border. And before you do the breast exam, you want to just examine the breast. You want to make sure that the patient is standing with their arms beside them or sitting, and also with their hands behind their back. and making note of the size and symmetry of the breast, and also having the patient lean up looking for any dimpling, lesions, ulcerations, or any abnormalities of the breast tissue. With the breast exam, you're going to be teaching the patient to do a breast exam at home, and it should not take more than 3 minutes. For the male patient, you will be not as extensive, but you will be palpating the breast tissue and all the way to the axilla, noting any tenderness, swelling, or abnormalities of the breast tissue, which could indicate gynecomastia. From there, we're going to go to the genital exam. For the female, you will have the patient in the lithotomy position with her feet in the stirrups, and she'll be properly draped. And you will do an external exam on the genitalia, looking at the labia, the urethral meatus, the vaginal opening. Notice any sores, lesions, any abnormal discharge, which could be concern for STI or any kind of infection. And then from there, you will be doing an internal exam with a speculum. You'll be looking at the cervix, noting any abnormalities such as discharge or any abnormalities of the cervix. You will remove the speculum, and then you will insert your hand while you have your other hand on top of the abdomen, palpating the cervix and the uterus, noting any abnormalities, making sure that the uterine tone is appropriate, feeling in all 4 quadrants. And then for the male genitalia exam, you'll be looking at the penis and the scrotum. You will be making note of the penis, seeing if there is any foreskin, making sure it's retractable, noting any ulcers, lesions, abnormal discharge, looking at the urethral meatus. And then you'll be palpating the scrotum, looking at the testes, palpating the testes one at a time. They should be distended and mobile. There should be no masses, any sweat, redness, swelling of those. And you will also test for hernias, femoral and inguinal hernias in the male patients, looking for any bulging, tenderness, or swelling in those areas. And for the rectal exam for the female, you can either have her in the lithotomy position if you're doing a vaginal exam, or you can have her in the left lateral position with her knees up to her chest, kind of in the fetal position. You'll be doing an external exam, looking for any hemorrhoids, palatal cyst, any abnormal discharge. You'll be using a lubricated glove to do the rectal exam, inserting, looking for any anal fissures, any cancer, or anything like that. For the male prostate exam, you will have the patient in the left lateral position. You will use the lubricated glove. You'll be looking at the anus as well, looking for any redness, cyst, external hemorrhoids, anything like that. And then you will use your lubricated glove to do the prostate exam, working counterclockwise, filling the prostate. It should be non-tender. It should be a rubbery consistency with no nodules or pain upon palpation. And that ends the head-to-toe assessment. Thank you for your time.